Hello everyone, a very good morning. So today my lecture will be on examination, diagnosis, treatment planning and preparing the patient for complete denture patient. So when you are going to come into year 5, the first and foremost, the kind of cases that you will be dealing with is complete denture patients and also removable partial denture, but um, it would be more of complete denture cases, and I hope that this lecture will help you all gain some information and knowledge about how important diagnosis and treatment planning is for the success of a good processes. So by the end of the lecture, I hope that all of you will be aware about the importance of diagnosis and treatment planning, then how a case should be presented, then how a case sheet has to be recorded, the order of case sheet recording, then being able to assess the patient's mental attitude, and also examine the extraoral and intraoral findings, then also analyze and come up with a provisional diagnosis based on the findings that you have seen in your examination. So looking at clinical history, so initially when your patient walks in, of course we do not have a separate or prosthodontic case history sheet as such, but the patient would have been examined in the Department of Oral Medicine and Radiology, and so by the time the patient walks into the prosthetic OPD, the personal data like name, sex, age, address, telephone number, occupation, all of these things would have already been noted. So at this point of time when the patient is walking in, instead of directly just jumping into what is the chief complaint, why have you come to prosthetic department, rather than asking such questions, I think it would be very professional that each of us should take that social responsibility of spending that extra minute to sit and speak to the patient, observe their chart, what they have been examined for in Department of Oral Medicine, and once you have a look at what has already been written or recorded in the case sheet, it makes your job much more easier in correlating what findings you will see when you're observing in the patient mouth and those that have already been recorded in the case sheet. So and as you all know, knowing a person by name is very important. How would you feel if somebody would just walk into the clinic and call you as some X? You would not be comfortable. So so is the patient also uncomfortable when you just refer to him as, yes, he is my patient. It would be rather professional when you address that person by name and they feel more welcomed when you address them by name. So it is always important to know the patient's name and you address them. And since we are always dealing at a professional level, we would advise that if it is elderly patients, very elderly patients, it is sometimes okay to add uh, as like auntie or something like that, but that is also not accepted. It would always be good if you can refer to the patient as ma'am or sir, and or otherwise Mr. So and so or Mrs. So and so. That would be more professional, and I would say that we should stick to that particular way of addressing the patients. And yes, for your further communication, you should be having the patient's telephone number so that you can contact the patient for the further appointments or if any changes have to be made. Yeah. So, in as part of your case history, we will be looking at systemic status. So, why is systemic status important? Because the general health of the patient will have an impact on the patient's oral condition. So, we will discuss about a few conditions which are most commonly seen in our patients here and what kind of an effect they have on the patient's oral health. So looking at the first and most commonly seen condition, that is your diabetes mellitus. So the conditions that you will oftenly see in diabetic patients is osteoporosis, so weak bone structure, then residual alveolar bone resorption. So that means that there is rapid resorption, and this might require an attention of replacing the dentures frequently. Then you would see delayed wound healing. Then you would see that the patient is more prone to infection. So sometimes any harsh procedures or any simple incision or a cut in the oral cavity also might not heal quickly, and there are also chances of super added infection. So that is why you need to be very careful. And in this kind of a patient, like a diabetic patient, your prosthetic point of view, we would always be looking at something at the level of impressions. We would do a mucostatic impression so that we don't over compress the soft tissue. Yeah, and also the kind of teeth, whether you are using semi-anatomic teeth or non-anatomic teeth, is what you have to take into consideration. And also the type of occlusion, because occlusion as such will be dealt with in a separate chapter when you come to year 5. But the kind of occlusion that you are going to give, whether it is going to be a class 1 relation or a class 2 relation or a class 3 relation, or a monoplane occlusion, it depends on the residual ridge foundation. And so we should not miss out on the details of recording or knowing whether the patient is a known diabetic and whether the patient is under medication or not. And preferably we should avoid any kind of a surgical intervention. Next, coming to cardiovascular disease. So in your case history, if it has been already recorded that the patient has a history of cardiac arrhythmias, or probably patient had undergone any bypass surgery, or the patient would give you a history that patient has got a stent that was placed in his heart. So in these kind of cases, what is the precaution that you would take? You should schedule the appointments early in the morning, so that they will not be stressed and they will be more open to get their procedures done. And the appointment time should be monitored. It should be short and quick appointments, and should not prolong for more than half an hour or 45 minutes, because the more time you make the patient sit in in the dental chair, it leads to anxiety, buildup of anxiety, and they feel more troubled when they're sitting in the dental chair. Yeah, for us as a dental fraternity to do any medical or dental procedures, it might sound like a very simple thing, but for the patient to sit in that chair, if you imagine yourself sitting in that dental chair, let me ask you this question: you would have undergone any dental treatment, something like a small, class 1 filling or a cervical abrasion, or maybe you would have undergone an extraction or whatever it is, or if you have undergone any root canal. How did it feel for you to sit on the chair for a prolonged period of time? You can understand and relate to the patient the amount of discomfort that they will be going through. So that is why you have to be empathetic, and also make your appointments short and quick. Next, coming to a condition called anemia. Anemia also, you will see that the soft tissue is usually very fragile, and also there is enhanced bone loss. And so as the bone loss is more aggressive in anemic patients, what happens is the ridge, residual alveolar ridge, is very minimal, and so the foundation for your denture is compromised. So your dentures will usually be unstable, and or otherwise they would be floating dentures. So they are not helpful in mastication or meeting the purpose for which it was made. And then there is also decreased healing capacity. So the patients who have anemia, because there is blood loss continuously, the healing capacity also is compromised in such kind of patients. Next, coming to arthritis. Elderly patients, when you see an elderly person while they are walking into your clinic, by the gait itself, you will know that the patient might have a history of arthritis. So when you're speaking to the patient, if you have observed the gait of the patient, then you should take an account of this condition and ask them if they have anything like a morning stiffness. So if they say yes, then that is definitely a sign that the patient could be experiencing this condition called as arthritis. So how is arthritis, which is a systemic condition, applicable to a oral cavity physiology, right? So as the bones in the body undergo changes, so are the bones in your oral cavity also undergoing changes. So what happens in an arthritis patient is that they experience like a crepitation sound or pain when they are moving their mandible. So as I mentioned in my earlier class, your mandible is a movable joint, and as you keep moving it to the right and to the left, what happens is there is pain and crepitation. So also there is a restricted movement. So the ball and socket joint, the temporomandibular joint movements are restricted and they cannot move it freely because of the stiffness or because of the pain that the patient is already experiencing. And also the tenderness in muscles of mastication. So, so when the patient is having any kind of tenderness, that is, so when you are doing, suppose you are doing a bottom mounting procedure for your patient, so that means to say when you are trying to mold the tissues, your upper and lower buccal flange areas, what happens is there will be extreme tenderness in the muscles of mastication area, and you will not be able to record accurately the peripheral tracing movements. And in advanced stages, yes, there is definitely disability and atrophy of the associated muscles. And then as the disease progresses, they have difficulty in wearing and cleaning of the denture. And other than this, yeah, as I mentioned already, so the impression making will be difficult, and also jaw relation. So already when the patient is experiencing pain while moving his mandible to the right and to the left, or while opening or closing, or when there is restricted movements, so to record the centric relation, to guide the patient into his or her centric relation, it is very difficult. So if the patient is arthritic, then you must be cautious in these particular steps. And because of this kind of a condition that is existing, you might not be surprised if the patient's denture looked okay during the trial stage, and when the patient has come back for his final denture, there are changes that were supposed to be made in the patient's oral cavity, and the occlusion seems as though it was recorded wrong. So in that case, then you must also be prepared to do frequent occlusal corrections. Next, coming to neuromuscular disorders. So, as age progresses and the patient is aging, definitely 70 to 80% of the patients will experience a neuromuscular dysfunction, I would say first. And of course, there will be patients who will be also having neuromuscular disorders like Parkinson's disease, Alzheimer's disease, schizophrenic, anything, that's a psychiatric condition, like something like a Parkinson's disease. All these conditions are associated to that slurred speech, that the facial palsy. So any hemiplegic patients also. So when they are having such kind of neuromuscular disorders, what happens is you will have a difficulty in guiding the patient again to record his jaw relation. So to guide the patient into centric, you need to have their neuromuscular coordination. So it cannot be achieved at one go. So jaw relations might have to be repeated, and it can be improved by the help of neurotropics. And also vitamin B6 and B12 administration can help in improvement of the condition. So what happens in usually in neuromuscular disorder conditions is that secretory activity is reduced, so the defense mechanisms of the oral tissue is also affected. Next, going to patients undergoing radiotherapy. So, osteoradionecrosis and necrosis of soft tissue is common, which implies that the treatment is coordinated, or, if required, the posterior occlusion should be such that it is reducing the stress on the underlying residual ridge foundation. So in these conditions, when they are undergoing radiotherapy, now with latest innovations, what we would do is, when we are suggesting a radiotherapy for the malignant conditions, there's something called as stents, which are fabricated or custom made for the patients, such that these stents will cover all the hard and to an extent soft tissue of the patient, so reducing the amount of radiation that is being passed or that is being sent towards the hard and soft tissues. So when these stents are placed in the patient mouth, these stents, they act as protective barriers, preventing the ions from penetrating and affecting the hard and soft tissues. So you can have a look at the picture which is shared in the next. Then coming to dental history. So once you have finished your medical history, once you are sure that the patient has been quite cooperative and patient has given his details completely about his medical condition, then you would go ahead with your dental history. We should always be cautious about noting the medical history, because always remember that the medical history has a direct connection to do with the oral manifestations in the patient mouth. So coming to dental history, the first thing that you would look at is why the patient has lost his or her teeth. If there are multiple missing teeth and there are only few teeth that are remaining, we have to find out, ask the patient what could be the reason. Is it because it was mobile, maybe a periodontal condition? Is it because the patient's teeth were quite decayed, so suggestive of rampant caries? Or is it because of any other cause or any kind of a trauma? Whatever it is, we need to find out what is the what is the reason for the loss of teeth. Next, coming to the previous denture experience. So if the patient is already a denture wearer, you would look at the patient's dentures. First, examine the dentures. How well are the dentures made? How well are the surfaces being polished? How is the occlusion? All of these things you would look at the denture first, and after that you would ask the patient to wear his or her dentures and examine the fit of the dentures, examine how the dentures are functioning, whether they have a synchrony with the oral tissues, whether they have been adapted to the oral tissues, or uh, is there any fault when you look at the dentures outside the mouth and when they're placed in the patient mouth. So you need to find out the duration for which they were wearing those dentures, then whether they were satisfied with the aesthetics, and how well was their speech affected or changed, then were they able to chew and eat anything that they liked, or do they have any issues with chewing efficiency, then how good is the fit of the denture. So once all these things about the old denture has been found out, then we can formulate the treatment plan, whether the existing denture is good enough to serve the purpose for the next few years, or whether it has to be remade, or whether there must be a tissue conditioning that is required, or if it is or if it's something like a relining that is to be done, or a rebasing. So based on the previous denture experience and what is the complaint of the patient, you will take your investigation or your diagnosis to the next level. Then, amidst all of this, the first thing that you would look at is the patient's mental attitude. So, this is a very important classification. It was given by Dr. M. House, and there are four different kinds of patients: philosophical, exacting, indifferent, and hysterical. So, look at it each in detail. So, when it is coming to a philosophical patient, I would simply say that patient is very sensible, and he will listen to you and be convinced easily with whatever you speak to them. They are very cooperative patients, and they will not unnecessarily have an argument or discussion, because they believe that doctors are supposed to be the ones who have more thorough knowledge in that particular field. The dentists are the ones who are having the thorough knowledge. So they are more happier, like trusting the doctor and allowing the doctor to make the wise decision in their treatment planning. So that is the kind of a patient who is a philosophical one. Then comes the exacting patient. So exacting patients are the ones who are like they need that extreme care, effort and patience, and usually his demands will be slightly more, and the patient is intelligent. Probably they would have done a small survey on the internet and found out whether the doctor is good or not, or that whether the patient's like what I would say, that like he will give certain expectations that that the doctor should meet before starting or finishing his treatment. Yeah. Then next, coming to indifferent patient. So in these kind of patients, what happens is that they're not really motivated to get their treatment done, and they act usually uninterested, and they would have definitely come to the dental clinic. It's because maybe somebody would have advised them, just go. So it's like for the heck of it, coming to the dental clinic, and then they show themselves. They usually pay a very deaf ear to the instructions that you give them, and they won't cooperate. And also, they, if anything goes wrong, probably the patient would have had a history or a past experience with a previous dentist, or if he had any past bad experience with the dental doctor previously he visited, then he would have definitely formed an opinion that all the dentists are like this, right? And next, coming to hysterical patient. Then coming to the hysterical patient, so these kind of patients are usually emotionally unstable, excitable, and excessively apprehensive. And also, these patients would be the ones who must be having or uh, uh, something like a psychiatric condition, or maybe they're psychologically affected because of something. So there must be some underlying problem, and they would come to a dentist. So rather than doing a new prosthesis, if you would have spent more time talking to the patient, explaining, and in your diagnosis you would have observed that the previous prosthesis is in good condition, and there are no faults about that denture, then probably you must assume that there's something much deeper that you would have to look at. And maybe uh, a small chat with the patient, like for 10 minutes. This would most commonly seen in like elderly patients. So when you tend to spend that extra 5 or 10 minutes with the patients, that they feel really excited and nice about us talking to them and giving them the attention. And so these are the patients who actually might not need a dental attention, but they must be something to do with the psychological issue. So if you can address those kind of problems, and psychologically if you can counsel them, then definitely it would be helpful. So then, moving on to clinical examination. So when you're looking at the patient's extraoral features, in the extraoral features, the first thing that you would look at your facial form. So there are three main types: square, ovoid and tapering, and also square tapering. Okay, so but these are the three main type of faces that you would observe. So you need to keep an account of what is the shape of the face of that particular patient, because based on the shape of the face, the teeth that you are going to use for the replacement must be similar to the shape of the face. And so you would choose which kind of teeth you would use for the denture based on the extraoral examination. So this is how you will look at the face shapes, right? So if you look at square, then tapering, ovoid and square tapering. So based on these external shapes, if you see that there are two lines that have been drawn, and these shapes are to be coordinated with the teeth that are present. And like these, the shape of the teeth, these are the ones. Either for square you use square, so there is a small coding that is usually present on the denture sets, which is marked as S or T or R, and that helps you to find out and figure out which kind of teeth that you must be using for the denture, right? And next, moving on to facial profile. So you would have learned, and you will definitely learn in your year 4. So according to angles classification, there are three types of classes. That is your class 1, which is normal, then class 2, which is retrognathic, and that is your mandible is pushed more inwards and your maxillae is more outwardly placed. And then coming to class 3, that is your prognathic kind of a mandible, wherein your mandible is pushed outside. There is a retruded maxilla and a protruded mandible. Then coming to facial symmetry, you have to see if there is any external swelling, whether the patient's face is symmetrical on the right and the left halves, or if there is any asymmetry that is present. Then coming to the facial height, so usually it should be either a normal facial height. So in normal facial height, your alveolar bone resorption is very moderate or minimal. Then coming to decreased facial height, that is the vertical dimension would have collapsed and the patient would have been a denture wearer for many years, like maybe more than around 15 years or 20 years, and the denture or the processes that was given was not good enough, so that might lead to decreased facial height. So and also this causes the appearance of wrinkles of the skin around the oral cavity. Next, coming to the third type, that is your increased facial height. So what happens is when the VD has been unnecessarily increased, when the patient's denture has been constructed, what happens is the patient's face looks more elongated because with the existing denture. So that is what you have to correct when you are doing a new prosthesis. Next, looking at the facial muscle tone. So the muscles of the face have to be palpated, have to be examined with the help of gloves, whether if it is a normal kind of a muscle or whether if it is flabby, or is there any spastic changes. Then you would look at the color of the hair and the eyes, whether they are black, gray, white or brown, and these colors are correlated with the shade of the teeth, whether you would use an A1 shade or an A2 shade or a E3, A3 or B1, B2, B3, etc. The shade guide that you have, you try to color match it, color code the shades, and then you would decide on the complexion on the color of the teeth. Next, coming to complexion. So then coming to complexion, if the patient, just imagine if the patient has got a very dark skin tone, it would be really unrealistic and unnatural to give an A1 shade for a dark complexion person. If the patient is very fair, and it depends on the kind of race they are also from. So maybe if they are from a Chinese patients, so usually they would have something like maybe sometimes they have A2 shade, sometimes they have A3 shade, and Indians have A1, A2 or B1, B2. So based or Malay patients would have A2 shade or B1. So it varies from the race to race. So you must also observe what is the complexion of the patient. Then coming to the lips, so you should also examine the thickness of the lip, whether the lip is thick or thin or normal. Then you would look at the length of the lip, whether the lip length is long or abnormally long, and there's more visibility of the denture, or whether if it is a normal lip length and exposure of the teeth is very subtle, and otherwise if it is short lips, so you cannot see any denture teeth or denture base, it's very difficult to identify. So examination of the face is primarily done for the selection and arrangement of the anterior teeth. So the examination of the lips and the face, till now all of these are very important because you are directly dealing with something called as aesthetics. Your examination of all these things has a direct impact on the aesthetic feature of the complete denture that you're going to construct. Next, coming to temporomandibular joint. So once this examination till here is complete, then you're looking at the TMJ. So there's something called as bimanual palpitation. So you hold the mandible. I would like to share some videos later. You would hold the mandible in such a way that your thumb fingers you stand in front of the patient. You place your two thumbs on the chin of the patient and your index finger on the joint that is at the condyle level, and try to ask the patient to open his mouth and close his mouth. So when the patient is opening and closing, if there is any resistance or any pain while opening, or if there is any deviation of the mandible when the patient is opening his or her mouth, or if there is any tenderness, or if there is limited mandibular movement, maybe OSMF. So these are the conditions that you will have to anticipate and see whether if there is any condition, any temporomandibular joint disorders, you know. These are the things that you will have to look at when you're doing the examination of the TMJ. And then your examination of TMJ, whether if it is normal or not, has a direct correlation whether if the centric relation of the patient can be determined without any kind of issues. Because if there are any temporomandibular joint disorders, or if there is any kind of a wear and tear of the ligaments or osseous structures, so then you might have to take a radiographic examination once again to make sure that everything is normal and reconfirm your provisional diagnosis. Then looking at the examination, I've already mentioned about it, bimanual palpitation. Then in your intraoral examination, you have the maxilla and the mandible. So if you look at the maxilla, that's a U-shaped, and if you're looking at the mandible, that's a V-shaped kind of an arch. Intraorally, a completely edentulous patient's residual ridge is, this is how it looks like. Then, according to a very famous author, Atwood, there is a classification that he has given. So, the residual ridge form. So, when the patient is walking into your cabin, and you know that the patient is completely edentulous. So, what are you looking at when you are observing the ridge? So, it is mainly divided into 6 categories. That is, the first one is pre-extraction, the second one is post-extraction, then third one is high well rounded. Next, the fourth stage is knife edged. Then the fifth stage is low well rounded, and finally it becomes as a depressed cavity, a depressed lining that you see in the residual ridge. So this is a very important Atwood's classification that would always repeat as a 2-marker, so you must take it into consideration. Then looking at the ridge relationship. So when the patient has been done like with the extraoral examination, we have already looked at how the patient's mandibular and maxillary arch should look like. Then you're looking at, also at the ridge relationship. So whether the patient is having a class 1. So in the picture, as you see picture A, there is a class 1 that is normal, wherein the maxilla and the mandible are parallel and also somewhat at the same point. They are more or less at the same level, and everything, the resorption also takes place uniformly. Then looking at the second picture, if you see that the mandible is retruded backwards, so this is a retrognathic condition. And next, coming to the third condition, that is your prognathic condition, whereas the mandible is brought a little forward, that is your maxilla is retruded and the mandible is protruded. So these are the three kinds of facial, the ridge relationship, and this is what you have to observe. Ask the patient to slowly bite, and you retract the cheeks and try to observe the ridge parallelism and see whether it is a class 1, 2, or 3 kind of a condition. Next, coming to interarch distance. So there are either adequate interarch space, or they might be excessive interarch space, or something like an inadequate space for the tooth that has to be replaced in the patient mouth. So if you have adequate intraoral space, it is usually 16 to 20 mm, and you can without any issues you can construct a complete denture. And if it is an excessive intraoral space, it means to say that there is residual progressive and rapid residual ridge alveolar ridge resorption. And so in those kind of cases, what you have to do is you must consider something like a fixed treatment, so that when you place implants, the bone is preserved from further resorption. And also it helps in stabilizing the dentures, because the lesser the foundation, the lesser is the ridge, and the lesser is the stability of the denture. So every time the patient would speak or move his tongue, what happens when there is no alveolar foundation, and the amount of space between the maxilla and the mandible is also very less, there is poor stability, and the dentures will keep coming or falling out of the patient mouth. Next, coming to your inadequate space. So when there is less space, what happens is it causes mechanical interference, leading to some biological changes in the patient mouth itself. So this is how your class 1, class 2 and class 3 intraoral space look like. Next, also you would look at something called as undercut in your maxilla. If there is any undercut area, so if there is an undercut, you have to see whether it is a desirable undercut or an undesirable undercut. If you think that the undercut would help in increasing the retention of the patient, then you have to you have to do a small block out and make sure that you would preserve the undercut and make the final prosthesis. Next, coming to bony irregularities pre-prosthetic surgery. So yes, in certain conditions, prosthetic surgery might be required, and they have to get it done mandatory, because we would not suggest any kind of a surgery without any information or solid news, whether if the patient is a good patient or a good patient for their surgery. And usually any kind of a surgical procedure is somewhat like what do we say, like something like a invasive procedure. So we should try and avoid as much as invasive surgeries. So if there are simple conditions like very mobile teeth or retained root pieces, all these things can be taken into consideration, but any other pre-prosthetic surgeries must be avoided. Then coming to oral mucous membrane. So oral mucous membrane, yes, when you see any changes in the oral tissues, you must be doubtful whether if the what do we say, whether the patient has any pathological condition, any precancerous lesions or malignancies or papillary hyperplasia or epilus fissuratum or any ulcers or sore points because of the existing dentures. So once you examine all of these, then you have a green signal to go ahead and do the next step of the denture. So if you look at it, there's a small epilus fissuratum, first picture. Second one, extraction socket is not healed. Third picture, you can see small root stumps in spite of extraction. And the fourth picture, you can see yellow color markings. That is also because of tissue abuse and not being treated immediately when they have some either kind of an allergy or something like that. Next, coming to palatal vault. So either there is a U-shaped palatal vault or a V-shaped palatal vault. Usually, when it is a V-shaped palatal vault, they have more deflective forces, and it is very difficult to balance the retention and the stability of the denture when we have V-shaped palatal vaults. But thankfully, this condition is not very commonly seen. Only very few cases where the pre-maxilla would have undergone any kind of changes during the birth. So those cases usually we would see a V-shaped palatal vault. So again, it is further classified as class 1, class 2 and class 3. So at the junction of the hard and the soft palate, the hard palate you can see, and at the soft palate. So at the junction of the hard and soft palate, the condition is considered as class 1 or normal. Next, looking at the classification of the soft palate. So, classification of the soft palate, what happens is, as you look at this picture, there is a small curve that is followed at the junction of the hard and the soft palate. So the angle that it forms, the soft palate or the soft tissue uh, of the oral cavity that forms with the junction of the hard palate. This is called as class 1 condition, in which usually it is large and it is normal, and usually the soft palate is extending at least 5 to 12 mm, the 5 to 12 mm beyond the hard palate, and at which point, so after 12 mm posterior to the hard palate, you can see that this curtain of the soft palate, it becomes the vibrating line when the patient is asked to perform the Valsalva maneuver when we are doing your recording of the posterior palatal seal area. Okay, in a class 2 condition, usually they form a 45-degree angulation and the distance is just 3 to 5 mm. In a class 3 condition, it is 70-degree and it is just only 1 mm. So posterior to the hard palate, it is just 1 mm that the soft tissue, soft palate will be seen. Next, looking at the maxillary tuberosity. So you have to see whether the tuberosity area is normal, whether there is any enlargement, or if there is any soft tissue enlargement, or whether it is abnormally enlarged, something like a hypertrophy or a pendulous kind of a maxillary tuberosity, or if required and if it is abnormally large, then you might require a surgical intervention, because it might interfere with the with the denture, and it might cause frequent dislodgement of the denture. Then looking at saliva. So saliva in itself, you are looking at the character of the saliva and the amount of saliva. So usually if it is a normal kind of a saliva, which is either mixed kind of a saliva, mucus and serous together, it is usually the most favorable. And then the thin watery saliva is supposed to be best for a retention, and or otherwise it would be both mucus and serous that would be best for the retention of a complete denture. If it is a thick ropey saliva, what happens is it complicates the impression making, and it sticks too hard on the denture, and sometimes to remove the denture out of the patient mouth, it is very difficult. Then amount of saliva. So if there are certain kind of conditions like xerostomia, usually there is decreased amount of saliva and also increased rapid caries. So if there is less amount of saliva, again it affects the retention of the denture. And also what happens is, if the patient would not have mentioned and you can see certain changes in the soft tissue, you should also probably question and say if the patient is undergoing any radiation therapy. So, or and in geriatric patients who are using any medication for hypertension, or even diabetes, or any nephrological issues, even the neurological patients, there's excessive amount of saliva. So based on the kind of medication the patient is taking, the amount of saliva will vary, and that will enhance the retention of the denture or decrease the amount of retention of the denture. So that's where you have to consider the amount of saliva that is seen in the patient. And then looking at the tongue. So based on the size, it is either normal, abnormal, or large. Then based on the tongue position, according to a very famous author Wright, it is classified as class 1, class 2, and class 3. So in class 1, the tongue, it is usually lying in the floor of the mouth, that is below the level of the incisors, your lower incisors, and it is slightly forwardly placed and just touches the tip of the incisors, or just below the incisal edges. Then if you're looking at a class 2 kind of a condition, what happens is the tongue is more like a flat and it's broader, because because of the absence of teeth, the tongue tends to grow into that edentulous space and become slightly broader, but the tip usually the tip of the tongue is again back in the normal position. That is where the palatal or the lingual surface of the lower incisors is. Then looking at class 3 condition, it is usually a retracted tongue and it is depressed in the floor of the mouth, and with the tip is curled upward into the body of the tongue, that you can see in this picture. So in your class 3, can you see that the tip of the tongue is curled backwards? So in your class 1, it is just touching at your just lower than the incisal edges, and in class 2 again it's flat and a little more broader, flattened and broadened, and then in your class 3 it is curled. Okay, so then coming to your frenal attachment. So in your maxillary denture you would see in your maxillae you would see the labial frenum, the buccal frenums. In the lingual in the mandible also you would see labial and buccal frenums, and also the lingual frenum, whether if there is a high attachment, whether if the attachment is normal or close to the crest, or whether if it's a broad attachment. Sometimes if it is very close to the crest, what happens is when the denture is seated on the residual ridge, it might impinge on the frenum and it might cause discomfort to the patient. So in that case, maybe a small surgical intervention might be required, and you can take the help of a skilled periodontist. Then looking at tori, so you have basically tori palatinus and mandibular torus. This you would have definitely seen in your clinical patients. So I would advise that when you are looking and assisting your seniors, I would say that you should observe the oral cavity and see if there is any tori also. They might usually interfere with the retention of the denture in your mandible. With maxilla it's not of much difficulty, but if based on the choice and the comfort of the patient, you can either relieve the tora area, or you can also still cover the tora area, and in very rare cases we go for surgical intervention of the tori, or otherwise it is usually not required. Then coming to gag reflex. So what is this gag reflex? Usually when we try to place an impression tray or an impression tray loaded with some impression material in the patient mouth, what happens is when when there is a contact between the material or the tray in the soft palate area, there is an exaggerated response and the patient tends to puke or vomit out the impression material, and they cannot bear that discomfort. So you need to see whether the patient's response for gag reflex is whether it is a normal slight response or no response at all, or if there is moderate gagging or severe gagging. So when you try to run your mouth mirror in the soft palate area, you will know whether the patient has the gag reflex, because you have to be very cautious. Sometimes what happens is the discomfort when you have already placed the impression material in the patient mouth, and if the patient is having an exaggerated gag reflex, what happens is the patient will begin to vomit or puke out all the impression material. So your material is a waste and you have to repeat the entire procedure once. Then coming to retromylohyoid space. So I'm sure you would have seen in your previous class that there is a retromylohyoid space in the lingual area, and this area is important because it has to do something with that of your stability of the denture, and it creates a peripheral seal. So if you're when you're placing the mouth mirror between the mandibular bone, that is your lingual fossa area, and the tongue. So if the mouth mirror is not visible and when the tongue is in its slightly protruded position, that's the most favorable. This you can observe in your clinically examining the patient, which can be demonstrated at a later phase. If suppose half of the mouth mirror is visible, then that means there is lesser retention. If the entire mouth mirror is visible, that means there is no residual ridge and the entire mouth mirror is visible, and it is very less favorable and it will not help in the retention of the complete picture. Then coming to special investigation, you would look at radiographs. Definitely radiographs are the most important things. For a complete denture patient, I would say that you would might have to do a panoramic radiography, which is a very important thing to not only see the amount of bone that is remaining, but also to make sure that there are no cysts or tumors or any residual roots or any existing abscess or any impacted teeth. So there are different kinds of conditions that you might see if you look at a panoramic radiograph. Although the exposure that is given to the patient than an IOP is slightly more in a panoramic radiograph. I would say that while doing an OPG, it is good to observe the bone anatomy through the radiographs, and this might also help you in planning for dental implant treatment. Maybe you might observe the density of the bone. Suppose if the patient is willing, if the patient is a completely edentulous patient and they are willing for implant treatment, so you might have to do a CBCT and examine the bone quality and quantity. And also you will see the the anatomical structures if they might interfere with the placement of the implant. Then is your diagnostic cast. Yes, when when the patient has already been diagnosed and examined completely, and you have come up with a proper treatment plan, a provisional treatment plan, then what you would do at your first appointment is that make a primary impression. That is your primary impression with alginate, and once you have prepared your primary major impression, then you would prepare a primary cast. You would observe it. You would see whether the ridge relationship is favorable or not, any other clinical findings that you have missed out while examining the patient, or if you were in a hurry and you have checked out certain things, then some conditions you might be able to figure out when you are observing the cast. You will also see if there are any one or two teeth that are remaining. What is the relationship between those two teeth and the relation of that particular teeth with your jaws as well. So, and then you decide whether a pre-prosthetic surgery is required or not. And also sometimes if there are undercuts that are present, you can also do a surveying whether any undercut removal has to be done or blockout has to be done. So if you and next, coming to pre-extraction records, if you have the patient prior casts models or patient's photographs, then when you look at the cast, then you might have some information as to what was the previous dentition of the patient, the kind of occlusal relationship, or if the patient had any periodontal condition, or the patient had any caries or anything. Looking at the anatomy of the teeth, of the remaining teeth in the existing model, you can figure out what has happened with the patient. And then looking at the existing dentures definitely play a very important role. So you have to ask the patient to wear his or her dentures and evaluate and see whether the patient's aesthetics are satisfied, the kind of teeth they have used, whether the phonetics are satisfactory or not, whether the centric relation has been recorded properly, the occlusal relationship, whether the patient's vertical dimension has been increased or decreased, or whether it is normal, and is the patient's denture adapted to the soft tissue properly, or if there is no retention. These are the things that you will look at when you're observing the previous denture. And you should also find out why is the patient wanting to get a new denture, in case if the existing denture is already well adapted. As I mentioned, in the patient's mental attitude, if the patient is hysterical, so you might have to see if there is an existing condition, that is a psychological existing condition, that you might have to draw your attention towards. Then looking at other investigation procedures, yes, to rule out diabetes mellitus, HbA1c or your random blood sugars would be a good test. Then the blood pressure, the hypertension levels, whether the patient is hypertensive or not, you can check with the blood pressure. Then you can also see whether the patient is anemic or not. And if you see any soft tissue changes, and which are suspective of any pre-malignant condition or a malignant condition, then you might have to do a biopsy or a swab that is required for histopathological examination. Then come up with a proper treatment plan. So in your treatment plan, the first thing would be your adjunctive care. So if the patient is already a denture wearer, educate the patient, motivate the patient if there is a requirement for a new prosthesis, or if there is any infection, remove the infection, any pathosis or abused tissues. So you might have to do a tissue conditioning. So you use a tissue conditioner, allow the tissues to heal, and only then you make your primary impression and go ahead with the next steps of fabrication of the complete denture. or otherwise if the patient has lost his diet and the patient is not well nourished. So in those kind of cases, you have to counsel the patient to as to which kind of foods would be good for him to eat, and which are suitable for the denture bearing patients. Then coming to your prosthodontic care. So in your prosthetic approach, you would either do a complete denture, which is conventional step, or if the patient is willing to pay, then you would look at something like an implant supported complete. So in your adjunctive care, as I mentioned, these are the points that you're looking at. And in doing the non-surgical kind of treatment for the abused tissues is the best thing to do. That is, you allow the tissues to rest by giving tissue conditioners, regular massaging. Then if there is any increased vertical height or any occlusal corrections that is required, that can be done. If the base is not fitting or adapted on the residual ridge, then you might have to do a refitting of the denture. Then you need to see if the patient's regular medication is having any effect on the soft tissue. So you might have to change the kind of drug, or the amount of the dosage of the drug must be monitored. And also, if required, vitamin B12 or B6. So vitamins, nutritional supplements also should be provided to the patient. So if you're looking at surgical methods, as I mentioned, surgical method should be the last thing that has to be as an option, unless there are certain conditions like a very hyperplastic ridge or epilis fissuratum, which is very painful, papillomatosis, or hyperplastic tuberosity, or these are the conditions you can consider a surgery. But if the patient is not willing, then definitely we should not opt for any kind of a surgical procedures. Then coming to frenal attachments. So considering frenal attachments, as I mentioned, if there is a high frenal attachment or a tongue tie or prominent buccal frenum, so if it is close to the ridge, so these are the things that you have to consider if there is any surgical intervention that is required, because they will interfere with the denture movement. So you might have to do a frenectomy in certain conditions. Then the other surgical methods, if you are doing a flap surgery, and if you are doing a vestibuloplasty, that is, suppose if the ridge is very shallow and you want to increase the depth of the vestibule so that you can improve the retention of the denture, that also can be done. And if it is a small lesion, like suppose it's a papillary hyperplasia condition, so and if it's a small lesion, then you would just scrape that lesion and send it for a histopathological examination. So that's how you look at a surgical way of treating the soft tissue. So once all these adjunctive care, the surgical or the non-surgical methods have been completed, then you're looking at the fabrication of the complete denture. So that's where your complete denture processes construction begins. That is with your primary impression, and then you look at border molding and secondary impression, then jaw relations and centric relation records, then trial denture, then final denture and denture issue. So these are briefly the steps. And so I hope that during my lecture you were able to understand the importance of examining the patient during your OPD, because it plays a very important role. The more the time you spend with the patient and sit and counsel the patient, you will not only educate the patient, but also you will be able to draw a lot of information on the patient's anatomy. So then you will also have information about the how the success, the prognosis of the denture. So suppose if the patient is already having something like a very resorbed mandibular jaw, so what happens, you should already convince the patient that he might not be able to have a very well fitting lower denture. It might be stable, but he will not have any good retention. So in that kind of cases, so you have to consider that you can convince the patient and tell them that preparing them mentally that this is the kind condition of your complete denture. So that's how you deal with the patients. And so that is why, and every part of your examination is a very important step, because if any of these steps have been missed, what happens is the success or the prognosis of your complete denture processes will be affected. So I hope that my lecture was clear, and I hope I was able to impart to you all the important points that were required in this particular topic. So if there are any kind of um, questions that you have or any doubts, please do reply back to us on the video, and let us know that, and we can have a discussion. And we are hoping that when we get back again to college, that we will be able to show you cases when you are assisting your your seniors. We can explain to you in detail, and also when you enter your year 5 clinicals. Thank you so much.